Yeah, our case presentation today, he is 57 years old, male patient who presented with headache, nasal and epistaxis. As usual, CT head and neck was done and MRI, then biopsy followed by PET-CT. CT head and neck, as shown, showed extensive nasopharyngeal mass that invading the base of the skull, invading the clypeus with intracranial, mild intracranial extension. Histopathology was obtained that showed non-keratinizing, poorly differentiated nasopharyngeal carcinoma. CK5, CK6 was positive, and Epstein-Barr virus was positive. PET-CT was done that showed excessive local disease with large lymph node. Then discussion in the multidisciplinary tumor board, head and neck, that recommended for neoadjuvant chemotherapy, followed by concurrent chemoradiation. The patient was seen by medical oncology team and planned for neoadjuvant chemotherapy. 3 cycles of TBF was planned, and the patient received his neoadjuvant chemotherapy. The patient started his neoadjuvant chemotherapy with good tolerance. Then the patient was did CT head and neck that showed excellent response to neoadjuvant chemotherapy. As you see, there is almost complete disappearance of the local disease and neck disease. Then the patient was seen at our clinic, radiation oncology clinic, and was counseled for concurrent chemoradiation. Our plan is to give him like 7 degree over 35 reflection over 7 weeks with concurrent cisplatinum on a weekly basis. Acute, subacute, and the late effect of radiation was explained for the patient, and consent was obtained. Also, the patient was assessed at the same time by medical oncology for concurrent chemotherapy. Next step was CT simulation. The patient was simulated at supine position. Head and neck thermoplastic mask was applied. The S type that covering all the head, neck up to the chest. Then the patient was scanned from the top of the head to the diaphragm. According to the departmental protocol, 3 millimeter slice thickness was obtained. Then the images was sent for our workstation. This is the CT simulation imaging. Registration and diffusion of the pre-treatment PET-CT, CT with contrast, prior and post neoadjuvant chemotherapy was used with the CT simulation. Then we started the contouring process that included GTV. Our CTVs, 3 CTVs was created, CTV 70 for high-risk disease, and CTV 63 for intermediate-risk disease, and CTV 56. Then the BTVs was also created, and organ at risk was obtained. This is the GTV drawn based on the post-chemotherapy volume for the primary disease and the nodal disease. Then the CTV 70 was created by adding a margin of 5 millimeter around the GTV. Also, the whole nasopharynx was included, and the whole clypeus was included, was involved basically by the primary disease. Then CTV 63 for the intermediate risk regions. Then the CTV 56 for the elective volume. Then BTVs was created by adding 4 millimeter around the CTV according to our departmental policy. Then the patient was sent for medical physics for plane creation. VMAT was used. Then this is the dose coverage of our BTV 70. Then the dose coverage for 63 for covering the BTV 63 using 95 coverage. Then the BTV 56 dose coverage as you see. Our dose constraints for all critical structure actually met according to the protocol, and our dose statistics was also reviewed. Then the case was reviewed in our CAT simulation meeting, and the plan was approved, and the patient now ready for treatment. CT was done during the treatment according to the protocol of our department in the first 3 days, daily in the first 3 days, then bi-weekly. I mean 2 times per week. Weekly follow-up of the patient during his treatment in the our OPD. Supportive medication was prescribed during the treatment that included sodium bicarb, local soothing agent like magic mouthwash, morphine syrup as per indication. Then 3 months after end of the treatment, PET-CT was obtained that showed the patient, alhamdulillah, achieved complete response. 6 months after that PET-CT, it means 9 months after end of the treatment, follow-up PET-CT showed discovery of a single hepatic focal lesion and a single T4 lesion. Also MRI local for the liver and for the spine was done, as you see. The case was discussed again at the head and neck multidisciplinary tumor board, and the recommendation was SBRT4 lesion and hepatic surgery referral for liver metastatectomy. Liver metastatectomy was done by the hepatic surgeon, and the post-operative pathology came as a metastatic nasopharyngeal carcinoma, poorly differentiated. Non-neoplastic liver showed non-significant pathology. Surgical margin came negative, and the tumor size was 1.6, 1.3 in 1 centimeter. Then the patient was seen at radiation oncology clinic and was counseled for SBRT4 thoracic spine lesion. Treatment rationale, benefit versus risk was in details explained for the patient, and CT simulation was done. Actually, for SBRT, we used 1 millimeter slice thickness. Fixation was done by Omniboard and VacLook for better fixation and better reproducibility. Then we drew the volume, the GTV that showed draw based on the MRI and the PET-CT. Then we created a BTV margin of 2 millimeter and CTV to include the whole vertebral body. Then the plan was done. This is a 95 dose coverage of our BTV volume, showing the excellent coverage. Actually, there is a small area of underdose near to the spinal canal, aiming to minimize the dose to the spinal canal. Our prescription dose was 31 gray over 3 fraction day all over 1 week, every other day. Dose constraint, we try to limit the dose to the spinal canal by a maximum of 18 gray, and for the spinal canal plus 2 millimeter to 19 gray, and spinal canal plus 4 millimeter to 20 gray. Esophagus maximum dose, we try to limit it to 21 gray, and great vessel, trachea, and bronchi, we try to limit it to 20 gray. Daily cone beam CT before treatment and during treatment was obtained. This is a DVH, all the dose constraints were met. So this type of management for the patient is an example for the management of the cases with oligometastatic disease. Actually, for better decision making, we have to consider patient factor, disease factor, and facility factor. Patient factors that include the disease status, primary disease need to be controlled, and the metastatic disease should be a limited number and accessible for management by different modalities. Patient factors that should be considered, including performance status. Patient is keen about his close follow-up. Then the facility factor that include availability of different treatment modalities like surgery, radiation, radiofrequency ablation, supportive care. All these factors will be helpful to take a proper decision for the management of these cases. Thank you very much.